Heart failure is a chronic progressive condition in which the heart muscle is unable to pump enough blood through to meet the body's need for blood and oxygen. Basically, the heart can't keep up with its workload. At first, the heart tries to make up for this by enlargement, developing more muscle mass, pumping faster. The body also tries to compensate in other ways, such as narrowing of the blood vessels and diverting of blood. This is a picture of the blood flow through the heart. Oxygen-rich blood, shown in red, enters the heart from the lungs and goes out to the body. Oxygen-poor blood, shown in blue, enters the heart from the body and goes out to the lungs. In left-sided heart failure, the heart's pumping action moves oxygen-rich blood as it travels from the lungs to the left atrium, then onto the left ventricle, which pumps it to the rest of the body. The left ventricle supplies most of the heart's pumping power, so it's larger than the other chambers and essential for normal function. In left-sided or left ventricular heart failure, the left side of the heart must work harder to pump the same amount of blood.
The most common cause of left ventricular dysfunction is hypertension and coronary artery disease. With coronary artery disease, the vessels that are responsible for supplying oxygen to the myocardium, the coronary arteries, are either diseased or damaged. Coronary artery constriction leads to left ventricular hypoxia. This results in a large area of ventricular wall hypokinesis, slow movement, or akinesis, absence of inward movement during systole, which decreases the force of left ventricular contraction and increases left ventricular end diastolic pressure. This causes an increase in left ventricular and left atrial preload. Preload is the degree of myocardial fiber stretch at the end of diastole and just before contraction. The heart enlarges and becomes less effective as a pump. This process is called ventricular remodeling. The decrease in force of left ventricular contraction decreases systemic blood pressure because of decreased cardiac output. The body tries to compensate by causing peripheral artery constriction, which in turn increases systemic vascular resistance, which leads to even more left ventricular hypoxia. Hypotension also causes the pituitary gland to release ADH, which causes the kidneys to retain water. The kidneys release renin, which initiates the RAA pathway, which causes sodium and water retention, which further increases left ventricular preload. Those with hypertension have increased systemic vascular resistance. The body compensates this resistance by increasing the force of left ventricular contraction, which requires more oxygen. Hypoxia causes a decrease in the force of left ventricular contraction, which is sensed by the aortic bodies. Found in the aortic arch, these baroreceptors sense a decrease in blood pressure and cause a sympathetic nervous system to release epinephrine, which causes peripheral artery constriction and further increases systemic vascular resistance, which increases workload. Cardiomyopathy is a disease that weakens and enlarges your heart. There are three main types of cardiomyopathy: dilated, hypertrophic, and restrictive. Cardiomyopathy makes it harder for your heart to contract and deliver blood to the rest of your body. Cardiac output is usually reduced and systemic vascular resistance is typically elevated. Dilated cardiomyopathy is characterized by progressive cardiac dilation, contractile dysfunction. Usually, hypertrophy is concurrent with this type of cardiomyopathy. Under microscopic evaluation, most myocytes are hypertrophied with enlarged nuclei, but many are thin, stretched, and irregular. If the myometrium is stretched or dilated too much, the force of contractility weakens. This concept is similar to a rubber band being stretched out and losing its strength. The causes of dilated cardiomyopathy are genetics, congenital defects, infections such as bacteria, viruses, fungi, and parasites, drugs, especially cocaine, and alcohol abuse, certain cancer medications, exposure to toxins such as lead, mercury, and cobalt, and arrhythmias such as tachycardia. Essentially, the left ventricular becomes tired from the rate being elevated too long. Hypertrophic cardiomyopathy is the abnormal growth or thickening of your heart muscle, particularly affecting the muscles of your left ventricle. As thickening occurs, the heart tends to stiffen and the size of the left ventricular shrinks, decreasing cardiac output. It is usually caused by a genetic mutation and is familial. Restrictive cardiomyopathy is the most rare form of cardiomyopathy. The left ventricle becomes rigid and less elastic, meaning the heart can't properly expand and fill with blood between heartbeats. Think about a balloon that has lost its elasticity and cannot expand.
Now we are going to discuss the clinical manifestations and the pathophysiology of these clinical manifestations that you may see with left-sided heart failure related specifically to decreased cardiac output. Here are the common clinical manifestations you will see. Fatigue develops because there is a decrease in blood flow throughout the body because of the heart's inability to pump blood out of the left side of the heart, which leads to a decrease in oxygen circulating throughout the body. The body then has to work harder to get more oxygen to all cells, making the body or the patient tired or fatigued. Weakness develops because, again, there is a decrease in blood flow throughout the body, which leads to a decrease in the amount of nutrients reaching all cells. Therefore, these cells cannot repair or maintain their structure, which can lead to these cells breaking down or wasting away. Also, cells throughout the body are unable to get rid of waste such as carbon dioxide because there is a decreased blood flow to pick up these wastes to carry it back to the heart and then to the lungs to be breathed off. This also can cause cells to break down. Oliguria during the day, which is a minute amount of urine during the day, develops because there is a decrease in renal perfusion because the body is trying to preserve what blood is being pumped out from the left side of the heart for vital organs such as the brain, heart, and lungs. Therefore, there is a decrease in the amount of urine produced during the day. Patients with left-sided heart failure may also experience nocturia, which is excessive urination at night. This is because the body isn't working as hard and fluid that had entered the interstitial space during the day is now returning to the vascular system, therefore increasing renal perfusion, which leads to an increased urinary output. Fluid enters the interstitial space during the day because of the decreased blood flow and gravitational pull from standing or sitting. Because of this, the body has to work harder to push blood and fluid back up to the heart to be recirculated. The body is unable to keep up with the large amount of fluid, so the fluid shifts to the interstitial space, which is also termed third spacing. At night, however, when patients are resting, decreased gravitational pull and decreased workload on the heart leads to increased renal perfusion, which leads to increased urinary output. Angina, which is another name for chest pain, can develop because of decreased oxygen to the heart itself because of decreased cardiac perfusion. This can be because of decreased cardiac output as well as tachycardia. Perfusion to the heart itself happens during diastole after the aortic valve has closed and blood can enter the coronary vascular system. This is because the coronary blood vessels are located just above the aortic valve, and when the aortic valve is open during systole, the valve cusps block the coronary vascular system. With left-sided heart failure, not only is the decrease in cardiac output a contributing factor to angina, but tachycardia can contribute as well. This is because the number of times the aortic valve is opening is increasing, therefore blocking the coronary arteries more often and decreasing blood flow to the coronary arteries and oxygen to the heart. Here is the picture showing the opening of the coronary arteries in relation to the aortic valve. If the aortic cusps are here, when they are forced open during systole, they move upwards, blocking the opening to the coronary arteries. Tachycardia and palpitations developing because of decreased cardiac output is related to baroreceptor and chemoreceptor-mediated reflexes, which are part of the autonomic nervous system. Baroreceptors are pressure-sensitive receptors located in the walls of blood vessels and the heart. If there is a decrease in pressure, like what occurs with left-sided heart failure, impulses are sent to the blood vessels to constrict and the heart is stimulated to pump quicker. So you have a decrease in cardiac output leading to a decreased blood pressure that triggers baroreceptors to cause vasoconstriction. The same happens when chemoreceptors are stimulated. However, chemoreceptors are sensitive to different chemicals within the blood system, such as oxygen, carbon dioxide, and hydrogen ions. Weak peripheral pulses, because of decreased cardiac output, is again related to the decreased circulating blood volume.
One of the major complications of left-sided heart failure is pulmonary edema. Pulmonary edema is an abnormal buildup of fluid in the air sacs of the lungs. To use a simple example, think of the drain in this picture as the aorta of the heart. The basin of the sink is the left ventricle, and the water that flows through the faucet is the blood coming from the lungs. When the left ventricle is not able to eject all the blood into the aorta, some blood is always left behind. This constant strain on the left ventricle reduces the effectiveness of this pumping mechanism and causes a backup of blood. When blood continues to back up through the system because of the left ventricle, it puts increased pressure on all the structures that lead up to the ventricle. Pressure increases in the left atrium and the veins and the capillaries in the lungs. Increased pressure in the veins and capillaries of the lungs causes fluid to leak out of the small vessels and into the spaces between capillaries and the alveoli of the lungs. This fluid accumulation interferes with oxygen-carbon dioxide exchange in the lungs. The body's lymphatic system attempts to balance the fluid leaking in the lungs by pulling the fluid back into the vascular or lymph system. If the fluid leaking from the capillaries in the lungs is greater than the amount of fluid being removed by the lymph system, the excess fluid will begin to leak into interstitial spaces, causing further pulmonary edema.